thank you, Dr. Omar Rashid, because he was the one who gave me the break and invited me to work with him. He's a radiologist, and I'm from a neurology background, but it is all because of my initial training with Dr. Omar Rashid at Lahore General Hospital that subsequently we developed our intervention program in the Army. And obviously, we have a lot of gratitude for Dr. Adnan Qureshi and Dr. Free Suri, because they were the ones who also gave us opportunity to work with them in US, and subsequently also proctored our procedures and gave a lot of support for developing our stroke program. So, Sir Mayor, we are grateful for your contribution towards developing the only comprehensive stroke center in the Army. So today, we're going to talk about a very interesting topic in which patients with acute ischemic stroke, they come with isolated occlusion of the internal carotid artery that may be intracranial or extracranial, with non-tandem occlusion and patent intracranial circulation via the patent circle of Willis. So once we classify these lesions, we can have either isolated external carotid artery occlusion, they could be internal with patent carotid T, or there could be involvement of the carotid T as in isolation with and without involvement of external or internal carotid artery occlusion. So these patients, they really don't do good if there's no intervention offered to them, and they have a very poor functional outcomes if not treated. And interestingly, these patients, there is a high tendency to deteriorate once placed on observation or medical management. And subsequently, the ICS, they recolonize, and these patients end up having recurrent strokes, either because of recolonization or because of hemodynamic compromises. At present, we don't really know what to do with these patients because we don't have any concrete evidence. And in the Hermes meta-analysis, there were 21% of the patients who had IC occlusion. And interestingly, there wasn't any patient with extracranial IC occlusion who were included in the randomized trial. So presently what we have is individual institution-based guidelines. So there are no concrete evidence-based guidelines as to what to do when we come across these patients. So what are the best treatment strategies? Which are the subset of patients that we should give only medical management, observe them? And should we give anticoagulants, antiplatelets? And if we do decide to do intervention, which are the category? And the major risk of doing an intervention is converting an IC occlusion into a tandem occlusion because of distal embolization, and then we end up doing a thrombectomy of the MCA. And one of the other questions that are still unanswered is that if you have these lesions and eventually you recolonize the IC, so should you do only angioplasty, or you should just stent as well? Because obviously you have to load the patient on antiplatelets, and there's always a risk of an intracellular hemorrhage with these patients. So we're going to try to answer all of these questions during this talk. So this is a study which was published in Journal of Neurology, and in which patients who had endovascular treatment, they were not included. Only patients who were offered only medical management were included. And the NHS was low with the median of N of 3. And in hemodynamic parameters, they set the target of systolic blood pressure of 120. There was no induced hypertension. And all of the patients, they were given anticoagulation. What they'd observed was a neurological deterioration that happened to patients within the first week. And they found out that those who had initial mismatch of 40 cc on the perfusion images, and they had flare vascular hypertensities with flare diffusion mismatch, they were the ones who deteriorated. And roughly about 20% of those, these patients who deteriorated, they ended up having an endovascular thrombectomy. Interestingly, up to 70% had very good outcomes, and 38% of the patients, they had a patent carotid by 3 months. So the question regarding anticoagulation and antiplatelets. Patients who have initially IC occlusion, they usually deteriorate within the first week, and there are various hypotheses for that, and one of them is that there's a propagation of the clot into the intraocular circulation or distal embolization, and it's because of that that these patients, once they were placed on antiplatelets, they had high incidence of strokes within the first week as compared to those who were given anticoagulation. And subsequently, once they realized that after about a year, the rate of recanalization was much more in patients who were anticoagulated as compared to those who were on antiplatelets. So the concept of flare vascular hypertension and the DWI mismatch is that once these patients come to us, so we're really not sure the actual aspect of these patients, and sometimes we do get an MRI to have a real appreciation of the damage that has been done, whether there's any clinical and radiological mismatch or not. So this is a very interesting concept, that patients who had flare vascular hypertension and there was a mismatch between the flare vascular hypertension and DWI, they did pretty well, and they were the ones who had a clinical aspect mismatch. So as you can see on this slide, this is the DWI, and this is the corresponding flare image, and you can see these vascular hypertension. So the mismatch that you can see between the vascular hypertension and DW almost corresponds with the mismatch that you see on the perfusion images. So this is something we can look at once we decide in how to manage these patients. So now coming on to the endovascular treatment, how to go about and what should be the criterias, and let's have a look at that. So this was the study which was published in the Neuro Interventional Surgical Journal, and this is the largest cohort of the patients that I could see or whilst I was doing research, and it's taken from the German registry. So what they did, they looked at the clinical and angiographic outcomes of these patients, patients who had initially tandem T occlusions versus those who had intracranial or extracranial occlusions. So most of the patients with extracranial occlusions, they had large artery atherosclerosis, and interestingly, 76% had TK score of 2B or 3. So the recanalization is not as high as those who present with tandem occlusion. And about 50% of these patients, they ended up having stenting, acute stenting, and with a distal embolization rate of 9%. So what's interesting is 32% of the patients deteriorated. So what initially happens is that whenever these patients, they come to the emergency, initially the deficit is not disabling and the deficit is not large. Then subsequently, after a period of observation, once they deteriorate, these patients undergo endovascular thrombectomy. And during that process, they end up developing infarct and the aspect goes down. And once you recanalize, then the outcomes are not as good as those in which we had intervened earlier. Similarly, the question regarding whether we should put a stent Umford or we should just do angioplasty and then wait so that if there is no reclusion, then we do the stenting. So there's another study which was also published in Neurointerventional Surgical Journal in 2018, in which 1 of 7 patients, they did up to 80% of the patients with acute occlusion, they did emergent stenting. And interestingly, only 7% had symptomatic intracellular hemorrhage. But in their series, the rate of distal embolization was much more as compared to the recent study that we just discussed. And another dilemma that we have is how do we decide whether there's a clinical radiological mismatch. So in Pakistan, there are hardly any centers which are doing automated perfusion studies. And most of the time, we depend on clinical aspect mismatch. So I wanted to see what was the, how does that predict outcome in terms of an automated imaging. So interestingly, the 90-day outcome of morbidity and mortality is almost equivalent if you have a clinical core mismatch or a clinical aspect mismatch. So it's very significant that you understand the importance of a clinical radiological mismatch, especially in these patients, because once we do perfusion studies, most of the penumbra is false, and it's very difficult to decide which is the oligemic part and which is the actual the penumbra. So it's the clinical examination and the clinical aspect mismatch which helps you decide in your treatment modality. So to sum up, this is the treatment strategy that we are following right now. So patients who have an NHS of up to 5 and they have a non-disabling deficit, and there is a negative clinical imaging mismatch, clinical, and there is a negative flare vascular hypertensity, DWI mismatch if you do an MRI. So these are the patients we usually do not embark upon endovascular treatment. And in all patients, we give anticoagulation, and we do a follow-up imaging at 3 months and 1 year to see if the carotid has revascularized or not. During this process, if any of the patient deteriorates and the NHS goes up to more than 5 or develops a disabling stroke, then we perform endovascular treatment. And for clinical aspect mismatch, we found it to be more useful and practical in helping us making our decision as to how to proceed with these patients. In most of the patients, if the aspect is good, then we do an angioplasty followed by stenting. But if the aspect is not good, and if there is a reperfusion injury, we see immediately on the Dyna CT, then we usually try not to put a stent and just keep the patient on a single antiplatelet and observe, and then maybe bring the patient back after 24, 40, 48, 72 hours and do a stenting if required. So the biggest fear that we have is the possibility of a distal embolization, and so this is a case of acute stroke patient who came to us with an extracorneal IC occlusion. The MCA was patent, and so interventionists, once they cross the lesion, there is a possibility that they'll throw a shower, and that will convert an IC occlusion simple into a tandem occlusion. So what we do is we use the modified daughter technique, but the only difference is that instead of crossing with a dilator, we initially cross the lesion with a glide wire, and then we move the diagnostic catheter over the glide wire. We're not using balloon assist. So you can see in this video, the guide catheter is being moved over the sheath is being moved over the guiding catheter. So we're not using proximal balloon arrest, or we're not using distal embolic protection device because most of the lesions there is occlusion of the opening of the ICA. So even if you have a balloon inflated guide catheter, there'll be retrograde flow through the external. So we found that this technique to be very effective because during the process of this procedure, there isn't any opportunity for embolization, and there is a flow arrest during all of these steps. So this was the image that we did immediately after. Once we crossed the lesion, we did the aspiration. So there was an underlying critical stenosis, and then we ended up putting a stent into it, and this is the final result with no distal embolization after this procedure. In the second case will be in which a 60-year-old male, he presented with 7 hours history of weakness, and aphasia was VAN positive, and NHS was 11. Aspect was very good, 8, and CT showed a mismatch. So we don't have an automated report of CT perfusion. We usually assess by visual interpretation, and this is the CT scan. The aspect was 8. The only hypotension that we could see was in the M4 and M5 segment. So since the deficit were disabling, NHS was more than 5, so we decided for an endovascular treatment. This is the CT angiogram. So this is the initial run that we took from the common carotid artery. So we did not know whether we're dealing with the dissection or we're dealing with occlusion distally of the ICA. So what we initially did, we crossed the lesion with a microcatheter, and then we had a microcatheter run distal to the lesion. And that also confirmed two things. One, that we're in the true lumen. Second, the MC is patent. And then subsequently, okay. Then once we crossed the lesion with the microcatheter and microvire, we did aspiration of the proximal segment, and then we performed the angioplasty of the most narrowed part of the ICA, and then so these are the static images showing critical stenosis of extracranial distal ICA, and then we ended up putting a balloon-mounted stent, coronary stent. So these are the I'm looking while it's playing. ठीक है, इसको play कर, इसको play कर, अगला next, ये, इसको आगे वाला यहाँ भी क्या यहाँ play कर. So these are the final images with TK score 3. There was no distal embolization or any dissection or any other problem with this patient. And this is the MRI of the patient, which was done after 1 week. He was discharged on NHSF2 and eventually had an MRS of 1. So to conclude, patients with isolated IC occlusion with disabling deficit and with clinical imaging mismatch should be considered for endovascular treatment. And stenting is safe, especially if the aspect is good. And if you decide to put these patients on medical management, then anticoagulation should be preferred over antiplatelets. And thank you very much. We're more than happy to take any questions if there are any.